Hi, Gabriella.
Hello, hi, and welcome everybody else. Hi, Alex. How are you?
I'm fine, thank you. How are you?
I'm good. Just having a quick look. Would you be able to try just sharing the screen with your slides? Just because we had a bit of an issue yesterday, just where it took a couple of attempts to get the slides going.
Mhm. Yeah, I'll try that now. Does that seem okay, Gabriella?
Yeah, no, that looks great. It's definitely working.
Fab.
I also like how you use the Mind the Bleep logo.
I know.
First speaker so far to have done that. So anyway, we'll wait a few minutes before starting. Yeah, we'll wait a
Of
few minutes
course,
before
yeah.
starting,
Sure.
just to give the stragglers time to get here. But so I'll turn it off for now. Yeah, just to say before we begin, I'll be posting in the chat function. I will monitor the chat function throughout. So if people want to ask questions at all, feel free to do so, and I'll interject when you finish speaking, but I can also save the questions until the end as well if anybody wants to ask anything in particular. We also have the feedback function, which is basically a feedback form. So for anyone that wants to get the certificate, you need to fill in the feedback form, and then it will automatically generate a certificate to you. And also just to say that this will be, it will, after a couple of days, because it takes a couple of days for Medal to process, it will be put up on Medal first in 2 to 3 days as a catch-up recording. And then afterwards, it will be put onto our YouTube channel. It just takes a little bit of time to process. All right, since it's 7 o'clock, I'll just start introducing and then we'll probably have more people join as we go on. But hi, my name's Gabriella. I'm the ENT lead for Mind the Bleep. We've been organizing a series of webinars to help people who are going into F2, SHO level, basically prepare for being the ENT SHO, as it may not necessarily be a topic that's covered in medical school all that much. So I've been organising a series of speakers to come and cover really important topics, which will hopefully stand you in good stead for your SHO job in ENT. Like I said, just a bit of housekeeping. There is a feedback form in the main chat. Please fill it out at the end. We really do value your feedback and go through it. And we also send it to the presenters as well to help them develop and reflect for the next time. And you won't get the certificate for attending unless you fill out the feedback form. We've been hosting these events on Tuesdays at 7 p.m. We have a couple more to go next week and the week after. And yeah, so this week's session is being hosted by the lovely Alex Bell, and it will be on common ENT procedures and skills that will be really useful for you going forward, especially because you're expected to act a lot more in an independent capacity. Anyway, I will, throughout, if you want to ask any questions, just put them in the messages box, and then I will pick up on it and ask, but at some points it may be more appropriate to ask the questions when Alex has finished speaking. So don't worry if I don't answer immediately. And there can also be a little bit of a lag. I've noticed a little bit of a time lag between you answering a question and it popping up on the screen. Anyway, thank you very much to Alex for agreeing to coming to do this talk. I will mute myself and turn my
I'm not necessarily looking at.
You're breaking up just a little bit. It's never time before. Unfortunately not. It's still a little bit crazy. I think your mic might be turned off.
Can you hear me now?
Yes, it's just a little bit robotic. I don't know what happened because it was okay at the beginning when you were talking to me, but for some reason it's coming through a little robotic.
Is this any better? I've just tried to change my Wi-Fi. I don't often have problems, but essentially it might have. It always goes at the worst possible moments, doesn't it? Is this any better?
I'm sorry, no, it's coming across robotic.
Let me just try the other one more time. Just bear with me. Has that made any difference?
I'm afraid not. I think.
Can I just double check? Because I think I keep watching your Wi-Fi bar on the side, and yours seems to be dipping in and out as well.
I don't know. Mine's come back at it being 100%. Would anybody else be able to comment in the chat how we're sounding?
Is everyone else having issues as well? Do you mind confirming in the chat? Oh no. I'll just try one more time going from maybe from data. Let me just start.
The only other thing I could suggest is perhaps if you've got the data available to go off 3G, it's a pain.
No.
I don't know what I suggest.
I just tried to go on my 4G. Is that?
Give it a moment.
Has that made any difference now?
I'm afraid not. It's still coming through. It's very robotic.
I don't know whether it's to do, because that's sort of 3 different networks I've just tried. Just wondering whether it's my laptop, but I've not had that issue before. I just tried my AirPods one more time.
It's very strange because it sounded fine when you joined the chat initially. Sorry, everybody. These things happen sometimes.
Thank you for being patient.
Hardware issue. But it's very, it's very odd just because when Alex was here at the beginning of the chat, it sounded okay. I think I'm coming through all right, unless someone else corrects me.
You are. I wonder if I just try leaving and coming back.
Yeah, no, that's fine. Leave and come back. Apologies, everybody. These things happen. If we can't get the sound to work properly, what we'll have to do potentially is just reschedule for another time. Really sorry, guys, but yeah, unfortunately, these things happen. Let's give Alex another chance to see whether she comes back. Okay.
Any better?
Right. Yeah, it's working fine.
Okay. Please do interrupt me if it goes again. That's really odd.
No, very strange. But yeah, no, it sounds absolutely fine to me. Can anyone else comment just to make sure that it sounds okay on the broadcast? Or just try not to move too much. Yeah, no, it sounds good. Right. Oh, no, you moved and now it's gone robotic again.
Oh, really?
Yeah.
I'm unsure. I literally can't imagine my laptop's failing you. Is it still the same?
Yes.
Shall I try and rejoin again?
Yeah. Go on, try again.
I'm very still.
Yes, no, it's working. Go on.
Okay. Let's give this a go. I'm going to pop my slides up now. Thanks for being patient, everybody. And again,
no worries.
Just interrupt me if the sound changes at all. Okay, finally, welcome to this event. Thanks everybody for being patient, like I said. Just an introduction to begin with. My name's Alex. I'm currently working as an ENT Education Fellow in South Manchester. And tonight we're going to be covering common ENT procedures. As part of my role, obviously, I teach fourth year medical students who are rotating through their ENT block at the hospital. But I'm also on the ENT rota, the SHO rota, and have been since August, so I should hope that I'm qualified by now to teach you about some of the stuff you're expected to cover on core. I'll just pop our slides up and we'll get started. I think it's fairly obvious it would be really difficult for me to cover every single possible ENT procedure that you may or may not be asked to do as an SHO in 1 hour. And it's also quite difficult for me to teach you some manual skills via the modality of a presentation like this. So I've done my best to try and stuff this presentation through with some practical tips. And generally, I've focused on 3 core procedures, and that's being sort of Quincy aspiration, foreign body removal, and Pinoy hematoma drainage. I'm not expecting people to recall every single step after, an hour's worth of teaching for each of these procedures. But what I'm really hoping to do is to try and give you that theoretical background and a little bit of familiarity with some of the ENT equipment, just so when you're on those first few weeks of your ENT placement, you're actually a little bit sort of in the know about things, and it makes it much easier to pick that stuff up once the registrar is teaching you. Like I said, I suppose in terms of formal objectives, we'll be going through those 3 key procedures. And I should hope by the end of this session, you should be able to recognise some of the common indications for each. But maybe more importantly, the ability to identify some red flag symptoms that might make you think you need to phone your boss before doing a procedure. And finally, like I said, just to be familiar with some of the major steps in each. It's probably relatively important for me to mention some of the things I won't be covering. Your next session in this series is obviously on epistaxis, so I know my colleague will be able to cover that in much more detail than myself. So I've left that out of this session. Equally, there's a couple of core skills that you use really frequently as an ENT SHO. One of them is using a sort of big microscope in clinical rooms to look in people's ears. So that's got sort of the eyepiece and the lamp, so you can do handheld procedures. And the other is the use of a flexible nasendoscope. So for anybody who's not familiar, that's just a piece of kit with a very thin fibre optic camera that we use to thread to the back of the nose at the postnasal space and look down at the larynx. I hope I've not disappointed anybody in not covering them, but essentially both of those skills are really hands-on, and there's very little point me going through it with you without you having the equipment in front of you. Every single ENT SHO joins their post not knowing how to do that and is proficient within a few weeks, so I really wouldn't worry about reading up on that sort of thing. So without further ado, we'll talk about Quincy Drainage. We'll probably spend the most amount of time on this just because it's such a common procedure that crops up on call. I'm probably covering some old ground really, because I know you will have gone through this in some of the previous presentations. But as you're aware, a Quincy is a peritonsillar abscess, and we use those 2 terms interchangeably. And more often than not, it's a sequelae of acute tonsillitis. So generally, proposed pathophysiology is that you get a bit of necrosis of that tonsillar tissue, and then you get suppuration, or the production of pus. And that collects in that tight space next to the tonsil. And it's kind of, that peritonsillar space is bound by your tonsillar capsule medially, pharyngeal wall laterally with your sort of superior constrictor. Anteriorly, you've got palatoglossus, and posteriorly palatopharyngeus. One of the key skills for any ENT SHO is, again, differentiating tonsillitis from Quincy. And it can be really frustrating in those first few months when you're constantly accepting referrals from GP into A&E with query Quincy, and they arrive and it's sort of bog standard tonsillitis. Again, I'm probably covering old ground, but the key symptoms to differentiate the two, usually people who have a bad Quincy have quite awful trismus, and that's obviously difficulty opening their jaw. And that's simply because you've got a collection of pus in the mouth causing local inflammation, particularly of your medial pterygoid muscle, which is clearly a muscle of mastication. And so it's all that inflammation tenses that muscle. It's very difficult to open the jaw. For the most part, people with Quincy have unilateral pain, or at least some asymmetry in the pain. And they often have that typical hot potato voice due to all that congestion at the back of the throat. I won't attempt a impression. I've learnt my lesson from a year of teaching that I'm not very good at it, but I'm sure you can hear a YouTube clip. But essentially, it's meant to be, you know, if you eat something very hot and you're trying to breathe around the food, it's that sort of feature, I suppose. And then clearly the definitive point that separates the two is the appearance of the peritonsillar space. So if you have a little look at this picture, there is clearly infection at the back of the throat, isn't there? You can see erythema, and there's clear enlargement of the tonsils, and actually it is quite asymmetrical. So in ENT, we often grade tonsils on how big they are. So grade 4 tonsils are all the way in the midline, and I agree that on the right side, that looks like a grade 4 tonsil. But actually on the left, the tonsil's quite small. But what's key from differentiating this from quinsy is, like, you know, you can see the anterior tonsillar pillar is perfectly well maintained, and the curvature is all there. And actually that shaded area that I've just put up is your peritonsillar space, and that looks nice and concave and there's no edema. Compare that with this picture where you can see obvious edema and loss of that demarcation. It looks fluctuant almost, and you can see that the uvula is pushed right over to the other side. Just worth a mention, there is a sort of condition called Peritonsillar Cellulitis. And essentially that just means you've got edema in the peritonsillar region without a collection of pus, and it often precedes a quinsy. They're very difficult to differentiate clinically. And realistically, if you see anything, regardless of whether you think that might be simple cellulitis, you need to treat it as a quinsy, and you often need to put a needle in it. You'll remember that your neck is made up of lots of fascial layers, you know, pretracheal, prevertebral fascia. And in between all those layers is what we call potential spaces. Obviously, if you leave a quinsy completely untreated, that inflammation and pus will tend to translocate down into the neck, into some of these potential spaces, and you can get a possible parapharyngeal abscess or deep space neck abscess as a result. And usually those people will present with very obvious neck stiffness. For the same reason that quinsy causes trismus, a parapharyngeal abscess can inflame, particularly your sternocleidomastoid, and that can give you that sort of torticollis appearance. Usually people with abscesses are systemically unwell, and a very late sign is obviously airway compromise. It's difficult because people who present with quinsy do tend to have very tender cervical lymphadenopathy and may say they've got neck stiffness. People with tonsillitis equally can present, you know, with sepsis. I suppose the point that I'm trying to make is, if you've got any concerns that this is more than a simple quinsy for any of those reasons, in the first instance, when you're just starting out, it's worthwhile speaking to your registrar. And later, you'll get used to scoping those patients to rule out parapharyngeal abscess. With any abscess, the obvious treatment is to drain the pus, because, you know, systemic antibiotics will only work so far. And the way that we do that most frequently is by attaching a needle to a syringe, putting that in the peritonsillar space and drawing off pus. And this is the sort of typical equipment that you need for that. So you can see on the very left, I've got a sort of blue box, and for people who've got good eyesight might be able to read that on the top. That's what we call Cofinal cane spray. And inside that box, it's got a little vial, and the solution in that vial is essentially a mix of lidocaine. So it's very good for topically numbing a mucosal surface. And it also is mixed with adrenaline, which is excellent for causing vasoconstriction and stopping bleeding. So we use it across a series of procedures in ENT. Inside that box, it's usually got a little nozzle with a sort of spray cap on that you can attach to the vial so you can use it as a spray. Next to that on the picture, you can see we've got a tongue depressor, followed by a 10ml syringe, and then finally the needle on the end. You can see it's got a sort of white base. So that needle is a 16 gauge needle, because obviously pus is very viscous. So trying to aspirate that with a really thin needle is near impossible because of the resistance. You'll find some seniors prefer to use a cannula because you can obviously get 14 gauge cannulas, which are the orange ones. And so they attach the needle to the syringe in the same manner. But it's a bit fiddly because you've got to get rid of certain things like the needle safety and the plastic tubing and whatnot. Finally, on the end, I've got a sample pot and a cup of water. And things that I haven't put on this picture are things like a vomit bowl, which you definitely need. And obviously your light source, which is usually a headlight that you carry around with you. So how to do it? Communication with this procedure is really key, and we'll come on to that in a slide or so. Usually just take verbal consent after explaining the procedure. Positioning is really important. As you're aware, if someone's coming towards you with a needle, patients have a tendency to try and draw back from insertion. So what you want is them upright, but also with their head resting on something solid. So usually that's, the bed sat up or a chair with a headrest. And you also don't want to be crouching down and peering into someone's mouth. You want to have the bed high enough that you're just looking directly in at eye height. Once you position them, you can put your head torch on, PPE, get your equipment ready. And then essentially you're going to ask the patient to open their mouth. With your non-dominant hand, use your tongue depressor to sweep the tongue out the way. And with your other hand, you're going to spray some of that Cofinal spray around the area of the quinsy. I usually then ask people to try and hold that solution in the back of their throat for as long as possible, because really you want to keep the solution in contact with the quinsy to sort of anaesthetize it as much as you can. It's important to warn patients, and you may try some of that spray at some point yourself, that Cofinal cane spray is very, very bitter. And sometimes as well, spraying it, they inhale a little bit and it makes them cough. You've just got to warn them and just ask them to try and suppress that reflex to spit it out. As long as they've held it for a few minutes, you can let them spit it out into a bowl or swallow it. That's safe as well. And I usually do it in two sort of separate squirts, just so they get used to that sensation of holding the fluid at the back. Next steps is to insert the needle. So back in the same position, mouth open, sweep the tongue out the way with the left hand. And with your right hand, you'll be holding the 10 ml syringe with the needle on the end. Insert it into the peritonsillar space and aspirate. Once you've aspirated as much as possible and all the pus has come out, you can take that instrument out and you just give the patient a glass of water and ask them to rinse and spit it into a vomit bowl. And you can empty that pus sample into a pot to send to microbiology. Just to talk a bit more detail about exactly how to do things, it's important to know exactly where you want to make that puncture site. So the landmark that's commonly quoted in sort of textbooks and things is the point of interception between horizontally the line that skims the base of the uvula and vertically the line that is at the medial border of your molars. And where that line intersects is where you want to put your first puncture site. Usually, you'd like to put that needle at about 1 centimetre depth. And you want to keep it fairly in the sagittal plane, so not wandering off laterally or medially. It's difficult, isn't it, to estimate how much 1 centimetre is when you've got a needle in somebody's mouth. So a technique that some SHOs use is they attach the needle to the end of a syringe as you usually would, but they leave on the safety cap that's usually on the needle before you take it out of the packaging. But what they've done, or what I've done in this picture, is remove the safety cap, cut off 1 centimetre from the end, and then popped it back on. So essentially, you can only put that into the tissue 1 centimetre because then it gets caught on the hilt of the needle protector. The theory behind that is that your common carotid is about 2.5 centimetres posterior and lateral to the peritonsillar space. And a theoretical risk is that you could hit that artery. I've never seen it done. I've never even heard of it done. I think it's mostly a theoretical risk. But when you're beginning, I think it's reasonable to use a safety needle just like this. It's important to give the pus time to fill the syringe, because it's not like blood where you get immediate flashback. It's viscous, so it takes time to get into the syringe. If you're struggling to get anything, you can gently adjust the needle angle, sort of withdrawing slightly and then reinserting. And then you can take the needle out completely if you're not getting any luck. Usually it's worthwhile trying a couple of times, but just adjusting your position. So you can see on that original picture there's 3 stars. You can try a bit superior medially or inferior laterally. Because obviously if there's a tiny collection of pus, you might just miss that with your needle, and it's worthwhile having another go if the patient can tolerate it. Final thing to say about technique is, obviously with your non-dominant hand, you are holding the tongue depressor. So with your dominant hand, you not only need to hold the syringe, but also withdraw the plunger. And sorry, you forgive my nails looking rough in that picture, but that's how I hold it, so that I've got one finger that can pull the plunger. We'll talk about some hiccups that you might come across when you're doing a quinsy aspiration. A really common response to you explaining what you're going to do to a patient is sudden panic. You want to put a needle in my mouth, or what to do in that situation. I think it's quite simple, really. You just need to communicate with them. Essentially, you need to reassure them that you do this procedure, every day in A&E. It's very common and low risk. Try and be explicit about exactly what you're going to do so they know what to expect and they trust what you're doing when they've got their eyes closed and they're not watching. What I think is really important that I like to do is formulate a communication plan, because when you've got an instrument in someone's mouth, they can't tell you to stop because they can't verbalize. So I usually say, if you really need me to stop, 2 taps on the bed and I'll take everything straight out. It's also good to go into the procedure with the caveat that this might just be simple edema and you might have something called a dry tap where no pus comes out, just so they're aware that's a possibility. And also to explain the sort of theory behind wanting to try again if you don't manage to get anything. A second possible hiccup. You go in to examine somebody in A&E, and as soon as you look in the mouth, you know that's exactly a quinsy. But the problem is the patient has such severe trismus that you can barely open their mouth. Well, I think we all recognise that trying to do a procedure in those settings is asking for trouble, because you've got a really poor view and the patient isn't going to be able to tolerate it. For the most part, people who are coming in with a quinsy, you tend to prescribe everybody the same thing. And that's those set of drugs that I've just put in that box at the bottom. One of them being dexamethasone. In most trusts, that's a 6.6 milligram IV stat dose. And it tends to help with the inflammation. And often after about half an hour, their jaw is really relaxed and you can reattempt the procedure. It's worth mentioning, often you can get sidetracked with the patients if you've got busy on call. And sometimes that patient has to wait. Try not to leave it too long for 2 reasons. Firstly, obviously, the steroids tend to wear off after a few hours. But secondly, sometimes they're moved up to the ward. And speaking from experience of trying to drain a quinsy on a ward at sort of 4 a.m. in the morning where the stuff all by the bedside, it's very poor lighting, it's just not ideal. You're better in an A&E cubicle where you've got space to put your equipment. And last thing, you've put the needle in, you've got some pus, but when you look back, there's quite a lot of fresh blood leaking from the puncture site in the mouth. Well, this is normal. What do you expect when you put a needle into a very inflamed area? As long as it's not spurting arterial blood, you have nothing to worry about. And it can continue beyond a few rinses, which sometimes makes patients a bit panicked. You just need to reassure them. You can just ask them to stop rinsing for a minute so the blood has a chance to clot. Theoretically, you can use some of the treatments that we use for post-tonsillectomy bleeds, so things like hydrogen peroxide gargle or dilute adrenaline solution. But it's really, I've never seen that required, or I've certainly never had to do that before. A last bit on Quincy. So what to do after you've done the procedure? Well, if it's successful, it's actually really satisfying because most patients feel so much better almost immediately. And often they're able to eat and drink after about 20 minutes. If they're tolerating oral intake and they can swallow antibiotics, their observations are stable, most of these patients can go home without follow-up. Naturally, if you've got any concerns that then they're not really improved clinically, or their observations are off, or they're not drinking, then you will need to keep them in overnight. If a patient has had 2 confirmed episodes of Quincy, and specifically that means you've put a needle in and drawn pus off, then actually those patients, that cohort, do qualify for a tonsillectomy as per the SIGN guidance. So it's worthwhile either consenting them or, listing them, or at least sending them to a consultant-led clinic to discuss it further. The other flip side is you occasionally see elderly patients with Quincy, and that should start to ring alarm bells because it's not very common above 40. If that's the case, it's worthwhile booking them in follow-up into a 2-week wait clinic just to re-examine them once all the inflammation is settled and rule out underlying malignancy. In terms of alternative procedures that do the same thing, you'll find some clinicians prefer incision and drainage of a Quincy. So essentially that just means instead of putting a needle into the peritonsillar space, you're making a shallow incision around that area. And it can be considered necessary if you've already punctured it and it's reaccumulated. Obviously the key difference is the use of a scalpel. Because it's a little bit more invasive, you can't really get away with the use of Cofinal cane spray alone, so often you have to inject the mucosa with local anaesthetic. Because you're not catching that pus in the syringe, it just falls into the mouth. So often you need a assistant with suction to hand. And sometimes you can dissect that plane if the patient can tolerate it. It's not something I do regularly, but sometimes it does vary trust to trust. Cochrane basically said that there's very low evidence to support one method over the other. But as you'd expect, I think reaccumulation is less likely with incision and drainage, but it's obviously a little bit more painful. That's it for Quincy. Let me just double check time. Okay. So let's talk about foreign body removal. I find this very satisfying part of the job, and generally you tend to get the best stories from it, really. I would strongly encourage everybody to start a foreign body hall of fame like I have at our trust, where you can record the weird and wonderful things that you remove from ears and noses. It's actually, whilst interesting, you're dealing with a difficult patient cohort. We often associate foreign bodies with children, but you've got to remember the adults that you see as well. And that's people with learning difficulties, people who've inserted it on purpose because of mental health issues, or very unlucky adults, usually with insects. I'm sure most of you know by now, red flags for foreign body removal are things like corrosive foreign bodies like batteries. If somebody phones you from ED triage with a query battery foreign body, then that needs to be top of the priority. And if you can't remove it straight away, then you need to start putting the wheels in motion for removal under GA. Naturally, there's a risk of airway compromise with any foreign body in either the nasal cavity, theoretically, but more commonly in the throat. If you've got any concerns about that, you would obviously speak to your registrar or get in touch with anaesthetics. Occasionally, you come across situations where there is a suspected foreign body, but you can't necessarily see it on examination. And usually the story goes, a child or a patient was unsupervised. You came back and they were with some objects that they could have put in their nose or their ears. Or, a child comes home from nursery and says, oh, I put something in my nose today. Essentially, when you come across that situation, you need to make a decision. Is this unlikely? Can I leave this and see if it gets worse and safety net them? Or is this something that I need to take further and investigate and think about examination under general anaesthetic? And there's sort of 3 key features that can help you make that decision. The first is how likely it is for that foreign body to be in that cavity without you being able to see it on examination. Most children that put things in their nose are relatively young, so between sort of 2 and 4. And they really do have very small nasal cavities. Sometimes parents are concerned they put something large in there, but for the most part, some of the large objects won't even fit in the nasal vestibule, which is the front of the nose. Most foreign bodies get lodged between your inferior turbinate and your septum. So if you can see a child's inferior turbinate and there's no signs of trauma, and there doesn't appear to be anything beyond it, it's unlikely for a foreign body to be in there. I say that, but I recently was embarrassed because I'd seen a young girl who'd come from a mental health institute, really, and a carer had told me that she'd put a long plastic sort of rod in her nose. And I examined with a Thudicum and I couldn't see anything. And I said I'd scope her just to kind of appease them. And I genuinely, to this day, don't know how she put it in there, but she'd really got this piece of plastic lodged. It's actually behind or kind of just adjacent to middle turbinate. I honestly don't know how she got it that far. But I suppose the point of that story is to say, you need to consider all options and just be sensible. It's probably better to err on the side of caution than be flippant and send everybody home. Other things that are obviously in keeping with a true foreign body being somewhere are symptoms of a discharge. So in the nose, that'll be unilateral rhinorrhea, particularly if it's foul smelling or if they've got new nasal congestion. In the ears, that's bad otorrhea or hearing loss. And obviously, if there's any chance of something dangerous like a blade or a battery, then you're much more careful ruling that out than other things. I suppose in the grand scheme of things, when you're just starting, you're just going to phone your registrar and let them make that decision. But those are some things to consider. With every foreign body, obviously, the goal is to remove it. And the key to removing foreign bodies is choosing your equipment wisely. You want to kind of have a preamble about what equipment you're going to use. The last thing you want to be doing in the middle of trying to remove a foreign body is fiddling around in your bag, wishing that you got something else out earlier. So we'll go through some equipment and some of the corresponding appropriate foreign bodies. So the first one, you can see these forceps on the left. They're called crocodile forceps, or colloquially crocs. They have a very delicate sort of forceps end at the tip and a really quite thin shaft. So they're great for getting things out of very narrow spaces. They're very good if you've got an edge to catch onto. So for example, paper, fabric, or on the right, you can see that's a hearing aid dome, and they have this brilliant sort of thin rim that you can just grasp onto. The problem, obviously, with beads is that you can't really get a good purchase on a bead with forceps, so you have to use something else. And on the very left, you can see the hand is holding something called a wax hook. Essentially, at the end of that hook, you've got a thin 90-degree angle bit of plastic. So that's fantastic for getting beads out, because essentially you can slide the probe past the bead and then twist the orientation of the wax hook so that 90-degree hook is sitting behind now the posterior aspect of the bead, and you can drag it out that way. You can use that second probe, which is called a Jobson horn probe, in the middle in a similar way. At one end, you can see it's got a kind of circular component on an angle, and again, that can be used for dragging objects out. And then finally, you can use some suction. If you suspect you're not going to be able to pull something out in one go and it's just going to break off, for example, bits of food, then suction's brilliant because you just hoover it all out. Obviously, every single clinical area has suction, including A&E and the ward. So usually, if you look at this picture on the very right-hand side, that's just suction tubing. You can hook that up to any suction on the wall. And then in the middle, that is our typical suction probe that we use in, looking at ears mostly. You can see it's a lot more delicate than something like a Yankee sucker. But it's great. You just hold it like a pen and suck things out. On the very far side on the left, that's what's called a foreign body remover, ironically. You can see it's a little bit different from the suction in the middle because it's got that tiny little blue piece of, it's almost like rubber on the end. And essentially that blue bit is like a suction cup. So it's designed to be able to latch onto round objects around foreign bodies and pull them out. The reason it doesn't get used very much is because actually that blue component at the end is quite big. So often for kids, who are 2 or 3, it doesn't really fit in the nostril. But it's something to consider if a child is older. Let's talk about the technique from removing a foreign body from the nose, because I think that's probably a little bit more complex than the ear. First stage is to try a procedure called mother's kiss. Essentially, if you haven't heard of it, the premise is that you use a parent and they position the child either on a bed or kind of cradled in their arms. And with one of their hands, they occlude the contralateral nostril on the other side to where the foreign body is. They take a deep breath in, and then they form a seal around their child's mouth with their mouth. And then they sharply exhale. And essentially that sharp exhale of air forces the child to close their glottis. The air then circulates up through the nasal cavity. And if you're blocking the other side, the air pushes against that foreign body that's in the nose, and often it can come shooting out. Most of the time when you're called from ED triage, they will have tried this. But it's always worthwhile trying it again when you get to the room, just in case they've not quite managed the technique, and you could try it a couple of times. Obviously, if that's unsuccessful, then you need to proceed with trying to take this out with an instrument. Best position to do that, or at least in my opinion, is having that child supine on a hospital sheet on a bed. Ideally, you want to stop the child flailing their arms around, so you can use the size of that sheet to almost swaddle the child and keep their arms tucked in. My registrar calls it a baby burrito. Then you probably want at least sort of 3 staff members, including yourself. So usually I have the parent holding the limbs underneath the sheet, and you kind of want them to be in the eye line of the child to try and settle them. And then usually I get a nurse to hold the head because I know they'll be a little bit more firm. What's really key is just making sure to communicate with all 3 of you very clearly. And what I usually say is, to parents at least, often children get very scared when we try and take things out of the nose or ear, and so they get upset. But what I'm doing shouldn't hurt them. What we want to do is do this very quickly in one swift movement to keep them in that position as little time as possible. But for that to work, I need them to be really, really still. And so we all need to be quite firm, to be kind, and get this out and get this over with. And usually that kind of triggers them to be a little bit more sensible about trying to keep the child calm. Essentially, then you can pop your headlight on and approach with your chosen instrument, and usually that's when they start to cry. What's really important, particularly if you're using a probe, is to make sure if you're holding the probe like a pen, you stabilize the rest of the hand on the child's face. It just means if the child's head moves, your hand moves with it, instead of having that probe hanging in free air, essentially where it could slip. So again, hiccups that you might come across. Often by the time you get down to where you need to see these patients, the world and his wife has tried to get this foreign body out, particularly if you're accepting referrals from sort of external hospitals. And often parents will say, oh, can't you just put him to sleep to get it out? my typical response is just to try and explain what actually having a GA would entail. So that means that we've got to put a drip in the back of this kid's hand, and that's a needle, and they don't like having it in. More importantly, they're not allowed to eat anything for 6 hours before the operation. And obviously we try and do children first on an emergency list, but I share that emergency list with every specialty in the hospital. So sometimes other operations will take precedent. The flip side is, if you're trying and the kid is extremely distressed and you just feel like it's impossible, then you have to recognise where to draw the line. You don't want to give this kid a complex about coming into hospital. Obviously, if it's a long-standing foreign body, it's usually buried in either lots of wax or lots of, sort of granulation tissue, and particularly if there's lots of infection around the area, that can be extremely difficult to remove without some anaesthetic. And equally, it can be painful, and those are all indications to just list for a GA. Another situation that you tend to come across in sort of emergency clinic is if you see an older child who's put something in their ear, usually to itch it. You can find they're very cooperative. They're positioned great under the microscope. But as soon as you touch that foreign body in the ear, they're sort of yelping out in pain and can't tolerate it. As you're aware, that deep portion of your ear canal, the bony canal, is just a very thin sheet of skin across the temporal bone, and it's exquisitely sensitive, as is your tympanic membrane. And if they've pushed a foreign body in so deep that it's touching one of them, even if you just touch the edge of the foreign body with your instrument, it's obviously moving, and that's really uncomfortable. In that situation, I'd usually just try and get a registrar to come and give me a hand. They might persist, or alternatively, just list them for an elective GA removal. Finally, common scenario, unfortunately. It's 2 a.m. and you can't get the speed out. What to do next? Well, it shouldn't make a difference to your decision, but for the most part, at 2 a.m., your registrar is off-site and asleep. And so it's about making a decision whether to phone them or bring them in, or leave things till the next day. It sometimes depends on where things are. So, for example, if you find a kid that's got a bead in its ear, actually a bead is an inert substance. So it's perfectly reasonable to send them home and bring them back to your sort of rapid access or emergency clinic to try and take that out with a senior around. The nose is slightly different. So there is a theoretical risk that they could aspirate that bead. Again, I've never seen that happen, but it's a possibility. So we like to try and get those out as soon as possible, really. If you can't do it yourself, then they're heading towards being put to sleep on the emergency list for an examination under anaesthesia and foreign body removal. So you can do that by either sending them home and bringing them back the following morning about 6 a.m. or just admitting them if it's really late at night. You need to make sure you're very explicit with how they need to fast before the anaesthetic. You need to phone theatre coordinator. You need to phone anaesthetics and inform them of the plan. And then you need to sort of organise with the PEDS team whether they're going to be admitted or whether there's space to have them on the ward in the morning pre-op. What to do after you've finally got the bead out? Well, it's traumatic for everybody, isn't it? Particularly for you if it's sort of 3 a.m, but often the child's crying, the parents are crying. So, you just need to try and calm everybody down. Let the child be taken into the parents' arms. Ideally, before they move, you just need to double check that there's no residual foreign body there. I had a case a few months ago where I thought I'd removed most of some foam that a child had put in his nose, but I wasn't sure. So we eventually ended up listing him for GA. And actually, when they scoped him, there was so much more in there. But more than that, they scoped the other side and found a piece of bark. So you don't want to send people home and have them represent 6 months later with lots of sort of bloody purulent discharge from the nose. More importantly, with the ear, you just need to make sure you don't need to give them some drops to cover for infection. It's tempting to give the parents the foreign body back, but you're asking for trouble. I usually tell them to take a picture of it. to remember things. Okay, probably about 10 minutes left if people can bear with me. The last thing I want to talk about is Hematoma drainage. Less commonly comes up on call, but it is one of those things that you need to be able to recognise and treat. Again, I'm sure you guys remember this from med school, but Hematoma forms as a result of direct pinna trauma. So we see a lot of patients who've been involved in contact sports presenting with this. And you have shearing forces that essentially strip the perichondrium from the underlying avascular cartilage. In doing so, you tend to tear the perichondrial vessels. They obviously bleed and blood collects in that plane between those two layers. And you can see that demonstrated in this picture down here. As a result, you've disrupted the blood supply to the cartilage. You tend to get a bit of pressure and avascular necrosis. And then you get remodeling of the fibroblasts very irregularly. So people get that deformity known as a cauliflower ear, if untreated. Pretty simple to spot, really. Defining features are that fluctuant pinna swelling. Sometimes it's a bit erythematous over there. For the most part, there's a history of trauma. We do see some people with spontaneous hematomas, but it's very uncommon, and usually they're on anticoagulants. And most likely, those people have bumped themselves and not even realised. For the most part, pinna hematomas are on the anterior surface of the pinna, obviously because that's more exposed. But occasionally you do get them posteriorly as well. It's worth examining for. There's not really any red flags in terms of differential diagnosis, but you will find that if a patient comes in with this, you tend to get called from ED triage and just say, oh, they've got a pinna hematoma, can you come down and sort it out? Well, actually, if you've had enough head trauma to cause a pinna hematoma, then you are at risk of intracranial complications. And as soon as you say that you've accepted that patient, they are your responsibility, whether that's to try and sort out somebody else to come in to assess them or deciding whether they need a CT head, etc. So it's just something to think about, asking the triage nurse very specifically. Do they have any concerning signs from a head injury point of view? So, similar to a Quincy, I guess, what do we need to do with the pinna hematoma? Well, you need to drain it. And the idea is that you clear out that blood, you reunite that perichondrium with the cartilage. And really what you want to do with the pinna hematoma is not let the blood collect again. So the way to do that is to apply external pressure on both sides of the pinna to keep those two layers pushed together. I've just popped some of the equipment that you'll need from a pinna hematoma. It's a little bit fiddly. Essentially on the end on the left, you've got a straight needle. And I'll come to this in a minute, but some dental syringes, some dental rolls as well. A scalpel to make an incision in the hematoma. And this at the bottom is two components of something called a dental syringe that they use in MaxFax a lot. Essentially, you load it with a local anaesthetic cartridge. The benefit of using it is it's got a very thin needle, but also the needle's quite long, so it's really helpful for putting anaesthetic in. And then you've got some chlorhexidine to wash the area, a syringe to irrigate the capsule, and then obviously everything that you've got in your wound pack: sterile gloves, a drape, a galley pot, and a little tray. When you open out that wound pack, you're very careful not to touch inside, and you can open your equipment onto it, and that becomes your sterile field. There's two ways to anaesthetize the ear when you're doing any procedure, not just pinna hematoma, pinna lacerations, whatever. The first is the one that tends to be recommended in sort of textbooks, and that's a pinna block. So a bit like things like ring blocks or fascial blocks, the point is to try and block the nerve at its entry to the body component. And obviously you've got several nerves feeding the pinna, things from your cervical plexus like greater auricular, lesser occipital, and then you've obviously got the branches of your mandibular nerve as well. The way to do it is usually or what's preferred is to use that dental syringe. So that's the same one I showed you before, but it's just loaded up. And can you see I put some cartridges on here? Often what we use in these is a solution called Lignospan. It's got a mix of local adrenaline and local anesthetic in it. Essentially, you insert that Lignospan around the ear by using 2 puncture sites. So to begin with, you'll put the needle in the inferior portion, just underneath the lobe, and then you tunnel your long needle very superficially up towards pre-auricular tragal area. And then as you're withdrawing the needle, you inject local all the way down that tract. But you don't take the needle out completely. When there's just the tip in, you change the orientation and you tunnel again towards post-auricular area and inject local anesthetic as you come out, and then you can take the needle out. And you do the same from the top, and then you create this sort of diamond area of local anesthetic infiltration. And that will give you completely numb pinna if done correctly. The shortcut way is to just infiltrate some local anesthetic around the actual hematoma or around a laceration. So usually you can just fan some local very superficially in the skin across the pinna and around that sort of area. Got to be really careful not to put the local anesthetic into the hematoma. That's very tender and it doesn't obviously numb anything. Only thing to mention is theoretically your pinna is an extremity. So you're not theoretically meant to use local anesthetic that's got adrenaline in it for that area. Whether people do or do not is I won't comment on, but if you want to use local anesthetic, it's probably worth just getting your registrar sign off with adrenaline, that is. So technique, again, communication and consent are key. We usually have these patients lying back on a bed with the head tilted slightly away. Just like if any of you have drained abscesses in general surgery, always a good idea to put an incontinence pad down. I know it's not very glamorous, but it's quite a messy procedure, and actually you're going to soak the patient's clothes if you don't put something down. You can then prepare the area with sort of chlorhexidine and then use a drape around the pinna itself, forming your sterile field. So a bit like what you do with a catheter, you know, when you tear out a circle of a drape, you can do the same and then just kind of hang it over the pinna. Then you can put your anesthetic in as we discussed. And finally, you can make an incision. So your incision is usually the lateral edge of that area of fluctuance, and you kind of follow the contour of the helix because it heals nicely that way. What you then want to do is just manually evacuate the hematoma. So you're just kind of milking that area of fluctuance towards your incision. And then you can draw up some saline in your 10 ml syringe and just irrigate out that cavity that you've left. And it's probably easier if I show you the picture really. Once you've evacuated the blood, like I said, you want to sandwich that area to keep those 2 layers in contact. And so you use a dental roll, which are those rolls of kind of like condensed gauze they use in dentistry a lot, on both sides of the pinna. And essentially you're kind of almost throwing a mattress suture through the 2. So you're going to thread your straight needle through the dental syringe, through the dental roll, through the pinna, directly through the cartilage, through the dental roll on the other side, and then back. And then you're going to tie it at the back quite tightly. I think I was an F1 when I first was taught this, and it seems quite daunting to thread a needle through someone's, the cartilage of someone's pinna completely. But actually, if you've done your local anesthetic well, they honestly don't feel anything. And it's actually not as tough as you would expect. You'd then do the same sort of stitch on the other pole of the dental roll, and then you can dress it. I'm struggling to think of things to troubleshoot with pinna hematoma. It's actually quite a simple procedure. Once you've made your incision, occasionally if you've not made your incision in the right place, you might not be able to evacuate that blood. There could be a few reasons. Have you made that incision deep enough? It does need to go past the pericondium. Have you made the incision too laterally, so over an area of edema rather than fluctuance? And also, you've got to remember, hematoma does solidify. So is it just really tough? Do you need to put a bit more pressure when you're evacuating? If you've done all those things, then I don't know why that would be happening. It's probably worth chatting to a boss about it. After you've finished, generally what you want to do is apply a bit of a pressure bandage. So if you make a slit in a kind of stack of gauze and fold that over the pinner, you can put a head bandage over the top, and it secures it in place. And basically tell the patient they can't sustain any more head trauma and give them 7 days of prophylactic oral antibiotics just because you've been fiddling near the cartilage. Usually we use ciprofloxacin. You want to see them again in your sort of emergency access clinic in a couple of days just to reassess it and make sure it's not reaccumulated. I'm just wondering if we've got time to do this.
No, I think absolutely fine, just because we had a bit of a delay to begin with. So I think just doing a few quick tips, because it's titled Quick Tips, I think should be fine. If there's anyone who wants to go or has somewhere to be, then obviously feel free to exit. But yeah, everyone else who wants to stay is very much welcome.
It's only 5 minutes.
Oh no, it's gone. Let me just sign off. I think it's gone a bit.
Yeah.
Try now.
How does that sound?
Yeah, unfortunately, it's gone back.
Oh,
I think you're going to have to maybe get it up on your screen and then exit and then re-enter again. Sorry, everybody. It's frustrating sometimes, but it's the wonders of modern technology. Unfortunately, it's robotic still.
I'll come out then, Gabriella.
Yeah. Yeah, in the meantime, if people would like to, if they've got any questions that they want to ask about anything from the past couple of slides or just the presentation as a whole, feel free to put it in the chat box and I'll ask Alex. Do you want to try it again? Let me just...
Is it okay now? I don't know whether you want to put it in the chat, Gabrielle.
It's absolutely
fantastic. Okay, let's crack on before it goes again. So last 5 minutes now, just some very brief tips on some really simple procedures that you might be asked to do, which take, literally a day to master really. In terms, occasionally we'll get called from from ED rather, to suture an ear laceration. If you can suture anywhere else on the body, then you can also suture an ear laceration. The key is to anaesthetize the pinner, as we've discussed, so either just with some local anaesthetic around the area or the pinner block if it's big. And then you want to use those teeny tiny sutures, so usually 5/0 or 6/0 of something non-absorbable like Athlon or silk. The problem with pinners is you really don't have very much tissue before you get to cartilage, so very often you'll be able to see cartilage in the wound. You need to make sure when you're closing that wound that you are covering the cartilage. Otherwise, you're leaving them very liable or vulnerable to sort of perichondritis-like problems. The other thing to mention, I hope you can see my mouse, sometimes you get lacerations that are completely through the helical rim. And when it's kind of hanging apart by that, the first suture that you want to throw is in the helical rim, particularly the most lateral aspect. As long as you can align the helical rim, then everything else falls into place and it looks really nice. But if you start sort of halfway across conchal bowl, then by the time you get to the helical rim, the edges don't quite match. So that's the most important thing to mention. And then you just bring them back in 7 days or so for suture removal, or get the GP to do it. Pope wicks, super simple. So very often you will see people with very severe otitis externa. So severe that their canal will almost be completely stenosed shut. Obviously, the best treatment for otitis externa is topical drops, but there's no way a drop is going to, get into the canal if it's that stenosed. So the best thing to do with that is to try and open it up with a little sponge, and that's what a wick is essentially. So you can see on that bottom picture, I'm just grasping a dry wick there. That's what it looks like when it comes out of its packaging. It's essentially a very small condensed sponge, almost like a pellet. And when you put water on it, it just expands up. And that picture at the top is what it looks like after you've put some drops in the ear canal. It just expands up like a soft sponge. The way to put it in is to grasp it as I've shown here. So at the sort of thin end, I guess, with usually Crocs. And then you want to align the tip of that wick with the sort of middle of the lumen, which is usually obvious. And then in one swift movement, you push the wick in. You can imagine, if you've got otitis externa that severe, pushing a hard bit of cotton to open your canal that's already friable is extremely painful. I hope it's not just me, but genuinely patients are sometimes, gasp out in agony, and often people are crying. The thing is, if you don't do it, it's never going to resolve. If you put some drops in straight away, then obviously that softens the sponge, and that can help a little bit, but essentially you just need to ply them with painkillers once that happens. If you've put a wick in, you need to take it out in about 2 or 3 days. If it's over the weekend, you just need to make sure they get the first appointment on Monday, or you bring them back sort of sooner. And generally, as the ear canal gets better, it opens up, and often those wicks just fall out at home. And then final thing, I know this seems incredibly trivial, but I've been called to quite a few embedded earrings this year, and you look like a bit of a div when you have to phone your registrar because you can't get an earring out. Often it happens that this situation tends to arise with kids because they're not checking the earring back as often as maybe they should be, and they obviously heal really well. What I would suggest is, that blue box of Cofinal spray, like I said, it's got a little vial of that local anaesthetic and adrenaline in. Essentially, if you just dunk some cotton wool in that, and then you just hold it on the area and kind of soak all those scabs off, it tends to just locally numb it, which is excellent. And then you can just kind of gently tease out something like an embedded earring back like this. Occasionally you see people in A&E where their earring back is stuck on the front of the earring and they physically can't get it apart. And, they've tried, their mum's tried, the A&E triage nurse has tried. So by the time that you turn up, it's a little bit inflamed. Because it's so difficult to get a gloved hand around those two components, what you can use is these sort of forceps. They're called Mosquito Clips, and you usually have them on the ENT ward because they use them a lot for valve changes with tracheostomies. Essentially, it's like an artery clip that they would use in surgery. It's got a ratchet on, so you just attach it to something and then you can lock it. So if you attach one mosquito clip to the back of the earring, one mosquito clip to the front, one big pull and it usually comes apart. That kind of concludes things. I hope for most of you that was at least a little bit helpful, and I hope it just has made you a little bit more familiar with things. I suppose from my point of view, to conclude, I just want to impart on you that the majority of ENT procedures, including all the ones we've talked about today, are really low risk. So they sound, occasionally when you first hear about it, they sound complex, but actually you'll pick up the hang of it really easily. And you look great when you head to A&E with your kit because no other specialty can do those procedures, and they're completely clueless until you come and sort it out. And that's really satisfying. For any of you that are interested in ENT or, like I said, have the jobs, you'll find that generally as a cohort, ENT seniors are really approachable. If you have got any concerns, particularly with people who have a Quincy, just phone them because they'd much rather know about potential concerns than not and find out, 2 days later when somebody's really unwell. Last thing to say, particularly for F1s and F2s who are interested in surgery, I would recommend you keeping a logbook of the procedures that you've performed. Less so now because they've changed some of the guidance, but when I was in F1, there was still a component on core surgical training, sort of self-assessment, that was essentially said something like, your skills are above those of your peers. And if you've got a logbook full of procedures like the ones we've just talked about that's signed by your supervisor at the end, it's a great thing to put in your surgical CV. And that's everything from me. So like Gabriella said, please do pop things in the questions if you want, in the chat if you've got any questions.
That was excellent. Thank you very much for coming to give the talk. It's given a lot of really practical, useful information, I think. And just to say, on the topic of procedures, I think they changed the core surgical criteria last year, but it's actually more in favor of procedures than it was before. And if you've performed a small procedure or if you've assisted in a procedure as well, so whether that's a procedure like you've mentioned in taking out the foreign bodies, but also if you've assisted in theatre, that's a really good thing towards your portfolio. I'm not getting any questions through at the moment, so I'm going to say please ask all questions now, or forever keep it to yourself. No, there's nothing coming through. But yeah, just to say thank you very much, Alex, for coming to give the talk and for giving up your time. It's been really useful, and I think it's been also really good to see the types of equipment that you use and the bits and pieces that you need to take around with you, because we get a lot of theoretical knowledge taught to us, but not necessarily practical knowledge, which is really good. And I know that for SHOs, there's currently some kind of national quality improvement project to teach people these skills before they start their SHO rotation, but it's not necessarily uniform across the country. But no, I don't think there's any questions. So I'm going to close the presentation, and I'm going to say once again, thank you very much, Alex. And there is a feedback form that's both in the chat and also on the feedback link to the side. We do take your feedback quite seriously in terms of trying to see the gaps and to see if we need to put on any talks in the future to fill those gaps. So do let us know. But yes, thank you very much for attending, everyone, as well, and have a nice evening. Thank you, and bye.